So next is cardio. Next is pre-op assessment. It's V28, and you have been asked to review a 75-year-old retired publican who is being considered for an open AAA repair after an incidental finding on the CT abdomen. He is non-hypertensive with chronic renal impairment. He had ST elevation MI 24 months ago and remains on aspirin and clopidogrel. Describe an ideal clinical risk scoring system. It should be objective, accurate, simple to perform, and economical. It should be suitable for both elective and emergency surgery based on information available pre-operatively. Consider both patient risk factors as well as the surgical risk factors. Can you describe some of the clinical risk scoring systems you are familiar with? American Society of Anesthesiologists, Revised Cardiac Risk Index, then PPOSM, NELA, and then cardiopulmonary exercise testing. So what is ASA? ASA1, normal healthy man. ASA2, a patient with a mild systemic disease. ASA3, severe systemic disease. ASA4, a patient with a severe systemic disease that is constant threat to the life. ASA4, moribund patient who is not going to survive without the operation. And ASA6 is a declared brain dead patient whose organs are being removed for donor purposes. Revised Cardiac Risk Index RCRI. It predicts the cardiac morbidity and mortality after non-cardiac surgery. Individual risk predictor using 6 variables, and then depending on the score, if it's 1, 0.9% risk of major cardiac event, if it's 2, 6.6% chance of major cardiac event, and 3 or more, 11.1% major cardiac risk. So physiological and operative severity score for enumeration of mortality and morbidity is called POSM. It was developed in 1991. Unlike ASA and revised cardiac risk index score, it takes into account the surgical risk and predicts the 30-day risk of morbidity and mortality based on 12 physiological variables and 6 surgical parameters. Then it may also be done as a colorectal PPOSM and vascular PPOSM. There are some surgical parameters which before operation it used as an assumption. And what is cardiopulmonary exercise testing? So it's a tool that can be used for risk assessment and optimization, as well as both diagnostic and prognostic tool for a variety of medical disorders, including coronary artery disease, cardiac failure, restrictive and obstructive lung disease. So Vascular Society of Great Britain and Ireland have recommended pre-ops cardiopulmonary exercise testing in the 2012 framework for improvement of AAA repair. And while how it is done, objective measure of fitness and cardiopulmonary reserve, cycle ergometer with the tight fitting of face mask for continuous gas oxygen analysis with 12-lead ECG, and non-invasive blood pressure monitoring. So mask, ECG, and blood pressure monitoring, and patient is sitting on the cycle and start cycling. Patient maintains a constant cadence of 60 revolutions per minute while a ramp protocol is applied to the cycle. Test terminated when the patient cannot continue due to dyspnea or fatigue, unable to maintain constant cadence of 55 or 60. If patient develops chest pain or arrhythmias. What is the hypothesis behind using CPET? Physical fitness predicts the surgical outcome. So self-administered questions due to activity status can be either an over or underestimation of the patient status. Major surgery induce systemic inflammatory response, and this stress response demands more oxygen and increased in the metabolic activity. The body responds by increased oxygen delivery to the tissues by increasing the delivery by 50%. Unlike body response to total metabolic during exercise, the oxygen extraction ratio after surgery falls to only 30%. 2 to 2.5 fold increase in the post-operative cardiac output is therefore required to match the oxygen delivery during exercise. However, increase has to be sustained for several days after surgery, so substantially greater cardiorespiratory reserve is required. Inability to match this demand leads to the post-operative morbidity and mortality. What is anaerobic threshold and what is its significance? So AT is a surrogate measure of the respiratory surrogate marker of efficiency of the lungs, heart, and circulation. Oxygen demand will begin to exceed the supply as the workload of the cycle is ramped up. This culminates in the muscle cells generating ATP anaerobically. This produces lactic acid, which will be buffered by circulating carbon bicarbonate, resulting in the increased production of carbon dioxide. The The point at which this occurs is called the AT and can be derived graphically from the 9-panel plot, a commonly used tool to interpret the findings of the study. An AT of at least 11 mil per kilogram per minute is required to safely undertake major surgery. Any number below that may require a post-operative critical care bed, and a degree of optimization prior to surgery should it be indicated. Thank you.